Welcome to Joint Effort with Des Moines orthopedic surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Welcome. I'm Dr. Jason Sullivan, host of Joint Effort. Tonight we have with us Dr. Paul Butler, who is Des Moines orthopedic surgeon's actually chief in foot and ankle surgery. And he's here to talk about different ankle disorders, including Achilles injuries, as well as some ankle fractures and some potential arthritis of the ankle.
Sounds good.
Welcome, Paul.
Hey, appreciate it. Thanks for having me.
No, thanks for coming on. Appreciate it. So Paul joined our practice about, was it 3 years ago or 4 years ago? 4 years ago now.
Yep.
And very quickly, you're already a medical director at a surgery center. Is that correct?
Yep, up in Ankeny. That's where my main office is, and then we've got a surgery center up there that the guys up there work out of. And yeah, it's great. We love it because it's nice to bring those services up to the Ankeny community, just because we haven't had a strong orthopedic presence from an actual physical location standpoint. But now being able to be up there for Ankeny itself, which is a growing community like crazy, but then also all the smaller communities around there, because when you're looking up into Polk City, Huxley, extending all the way over to Bondurant, Altoona, Pleasant Hill, all that type of stuff, that area is just growing and growing. And so it's nice to have patients to have a closer home. There's nothing wrong with coming out to West Des Moines, don't get me wrong, but at the same time, it's nice to be up there, and we love our home up there.
Well, I recall the decision to bring an office up there. You essentially created a practice out of nothing, out of a vacuum, correct? Were you one of the first guys in that office?
Yeah, and so there were three of us that are up there, myself, Dr. Brunkhorst, and Dr. Isaacson. There were some of the main folks that went up there in the first place, and just going around and meeting the community. And it's even crazy now, after we've been in this building now for over 3 years, and we still have folks that come in, and they're just like, hey, I never knew you guys were here. And it's just like one of those things is that, you just don't know until you get out and about, and it's good that a lot of people don't know that there's orthopedic surgeons around the corner, because that's mean they're not hurting.
Yeah,
and
for
so
sure.
but at the same time, when these problems arise, it is nice to have those folks to where they're like, hey, this is close to my home.
You're the neighborhood
base.
doctor instead of having to travel 30 minutes to Des Moines or whatever.
Exactly. And so yeah, I think it works out well, and it's just nice because being in the community myself, and then the other guys are up there as well, and it's just it's truly our home. I still come out to West Des Moines a couple times a month to help take care of different patients that live in different areas, and just convenience factor for people. But yeah, we enjoy it up there.
So you are from a marriage of two docs.
Yep.
So your wife's in medicine. What does she do?
She's a peds hospitalist over at Mercy. And so, yeah, we're going in different directions a lot. And so it takes a lot of planning from schedules and so forth. But yeah, it's worked as well.
Did you guys ever have a discussion like, hey, at the end of the day, let's not talk about our careers? Or how's that work?
There are times like that, yeah.
You're just like, hey, I can't hear about one more sick kid, and she's like, I can't hear about one more foot or ankle.
Yeah, I think it goes both ways though, and so there's definitely those scenarios where it's like, hey, we just got to change tune, and we've got a couple young kids and things, and so they're always changing the topic of conversation.
But a level of understanding, I would guess.
Exactly.
If you come home frustrated, most of us come home, long day, whatever it may be, and the last thing any of our spouses or kids want to, no one wants you to bring work home, but if you bring it home, I would guess she could help address it with you in 5 or 10 minutes and you move on? Yeah,
it works out well. And so, it definitely goes both ways.
And so you're the father of two now. You have a newborn.
Yep.
How old?
3 months. So I got 3 months and 2 years. And so, yeah, they're going in different directions all the time. And
so born on like day one of quarantine from COVID, or
pretty darn close. And so I guess if you're going to spend
that'll be a story for your kid.
I was going to say, if you're going to spend quarantine anyway, you might as well spend it at home with a newborn, because you're not going anywhere
else. Were you
else.
allowed to be there when the kid was born?
Yeah, we were.
So dads are still allowed.
Yep, and that was it. But you're pretty much in lockdown in the hospital and all that type of stuff. It's crazy deal.
Okay.
But that's kind of what everybody's living these days.
Yep.
And so, but yeah, it'll be a story for the next generation.
So I know you like being outside, and I know you enjoy golf.
Yeah.
I made the mistake of, when you joined the practice 4 years ago, inviting you out to play, thinking, show them the ropes, and then you went out and just beat me in front of my friends. It's okay. But you were a pretty good golfer. You played in high school.
Yeah, and so played kind of back in the day, become definitely more recreational and social since then.
Did you think about playing at Drake, or was that a possibility?
Kind of thought about it, see how it'd work, but then kind of when the things come up of whether, it's kind of like where are you going to go with things? Are you going to be a professional golfer? Are you going to be, going into something else career-wise?
Right.
It kind of rose to the top where it's like, hey, you know what, we'll focus on the studies, and, still always being nice to be able to go out and use it as a commonality amongst people. And
you weren't going to make the PGA Tour, so you thought this is a more stable environment for the future.
Yeah, that's kind of the way that it's going right now.
So from Drake, you went to Iowa for med school.
Yep.
And then Grand Rapids for...
Yeah, went up to Grand Rapids, Michigan.
That's an incredible community program.
It's
correct?
awesome. It's awesome. Grand Rapids is great. Maybe it's just me being naive from Iowa and not knowing much about the state of Michigan to start with. But I went up there and met with those guys, and they've got the second oldest orthopedic residency program in the country.
Is that right?
Yeah, and so they've got a long history. They've had long development of the program and working with the different hospitals in the community and docs and so forth, and amazing training. And then I actually stuck around and did my fellowship up there as well. And it was
usually a good sign.
Yeah, and so I'm going to say it's coming from somebody that did something similar, right?
Well, med school and residency at the same place. So, I mean, they couldn't get rid of me. But for you, they probably selected you to be their foot and ankle fellow, right?
Yeah, and so stuck around, and the guys up there, they're well respected within the foot and ankle community, and they work hard, and so it was a lot of good minds to work with, and then also definitely staying busy and having high exposure. So that's what you need before you go out there and you're all on your own.
You need to see a bunch of things.
Yeah, and
because when you start on your own, you're on your own.
Well, yeah, and that's the biggest thing. It's like, you know what? I mean, there's stuff that happens 0.5% of the time or 1% of the time. It's okay. That's great that you did 10, but statistically, you got to be seeing 100 of these before you're able to see those complex things and be able to differentiate the minutia that's out there of saying, okay, is this normal? Is it a variant? And kind of how you make those decisions clinically and how to put people at ease when something, hey, we're okay.
Yep. So foot and ankle seems like in the last 5 or 10 years has become a pretty popular fellowship choice. Is it getting more popular?
It has. And
why is that in your mind?
I'm 100% biased.
Of course.
And so, from my perspective, I think the big thing is that when you're looking at foot and ankle, I think maybe people are just learning more about it. And from an orthopedic perspective, and kind of the cool thing is, one, I think that it's intellectually stimulating because it's a complex area of the body, and it's the first thing that strikes the ground. And so I always say that the little kid song, the hip bone's connected to the knee bone, it's connected to the foot.
Yeah.
And so it's how you strike the ground.
Is that as in depth you get with your practice too?
Yeah.
Is it just that simple?
Yeah, we basically have crayons and coloring books and stuff like that in the clinic, and that's about where we're at. But sometimes drawing pictures is all we need, and that makes the most sense to people too, and so it works out well. But I think the big thing is that taking something that's complex and then trying to simplify it into, okay, what makes sense to people, the lay person, and so then they can walk away from a visit and say, okay, why am I having this problem? What do I need to do, or what can they do on their own without even, maybe even needing to get more in depth at that point? But just the understanding.
So you view yourself almost as a consultant to inform people as to their problem, because a lot of these things can be corrected with postural changes, orthotics,
stretching,
therapy, stretching.
Completely.
Speaking of stretching, I think I called you like 3 months ago. I could barely walk on my right side, and in like 3 minutes, you're like, hey, man, you need to stretch your calf.
Yeah.
I was like, is that simple? Huge. He's like, yeah. And so I did that, and it's gone.
Yeah. And say if there's anything for anybody that's got foot and ankle pain, there's always exceptions, of course, right? But I think across the board, it's like the amount of people that come into my clinic that just have tight calves, and they come in and they're like, hey, my big toe hurts, and then eventually we're having this conversation of how it's all connected,
right.
Literally the thing that you're right, exactly, and they're like, nursery rhymes, here we go. And so, but it's all connected, and they're just like, oh yeah, they're like, it's because I'm putting too much pressure out there too. It's like, maybe I have some arthritis or whatever the case, but I'm putting too much pressure, so if I can get some off of it, then I can hopefully back off the pain or whatever problems we're working with. So yeah, definitely stretch, and that helps, everything from the foot up to the ankle and the Achilles and all the way up the chain.
So let's talk about the Achilles, because as we both enjoy sports, and we know the Achilles injury can be a career changer, if not a career ender for a lot of people.
Totally.
And this became popular. Kevin Durant, I believe, had Achilles tear. Yep. Kobe Bryant, about 7 years ago, had an Achilles rupture. the list goes on and on. Not all athletes get back to playing after their Achilles tear. Is that correct?
Yeah, and so when we're looking at a professional athlete perspective, they definitely have different demands than us. Even though sometimes we try to think that we're at the same level, but yeah, exactly. But when we're looking at timetables and expectations, because that's always a big thing of saying, okay, where am I at today, and then where can I expect to be at 2 months, 6 months, 12 months. And we've shown that from those professional athletes that about half of them retire after they tear an Achilles. And so, that's disheartening to myself and so forth. It's like, okay, man, if I blow mine, what am I going to do?
Why, in your mind, why is that?
Confidence. The brain is crazy. And
really?
It is. It's because the whole thing is that kind of situation is that, when people tear their Achilles, they literally they push off and somebody's like, hey, who kicked me in the back of the heel? Mm-hmm. And it's because you don't think about your Achilles at all during the day. Mm-hmm. You take it for granted, strongest tendon down in the lower leg, connect down to the ankle, and you just trust it. All day, every day, you expect it to be there. But when it's not, your brain says, what? What's going on? And
what does Achilles do for people? Just as rudimentary as you can get. It comes from what muscles, attaches where, and what purpose does it serve?
Yeah, so from a big picture perspective, you've got two main muscles in your calf, your gastroc and soleus, and it runs down to your heel bone. And it provides your push-off strength to be able to walk, jump, run, sprint, all those types of things. And so the thing is that even if you're, whether you're 80 years old or 8 years old, every time that you push off, go up and down a step, you're using that Achilles. And that's giving you your push off and gives you balance, and it just allows you to live your life. And so the thing is, we take thousands of steps a day. And for thousands of steps a day, today I haven't thought about my Achilles once.
Okay.
But if your brain doesn't have that connection.
Not even as a foot and ankle guy, you're not thinking step, oh, that's my Achilles there.
And say I do when I'm tight and I haven't stretched my calf muscles, then I think about them because they hurt.
Is being tight a precursor for rupture?
Theoretically. And so it all comes down to general biomechanics of if you're over-tensioning something for, once again, thousands of cycles a day for, hundreds of thousands of days when you're adding everything on top of each other, it's just increased wear and tear. And so in addition to that, that puts a little bit of a precursor, but then there's also some genetic variants of how blood flow is derived, whether somebody's had some previous scar tissue in the area. So there's a lot of other variables, but definitely, I've honestly can't think up off the top of my head where I've had somebody that's had an acute Achilles tear. I examine their other side, and they're loose and have great motion. It's like, you're tight over here, and it's like, hey, has this been sore? And they're like, yeah, it gets kind of hot when I play basketball. And it's like, yeah, it's because this was...
They had it coming then.
Yeah, and it's not necessarily that you had a problem before. It's just that we've been overstressing this structure for so long. It's just that, unfortunately, it just happened to be that day.
Is there such a thing as a partial tear?
Yes and no. I think kind of in the big things, if we're talking about kind of Achilles tendon treatments, it's the Achilles works or it doesn't.
Okay.
And so in the grand scheme of things, I think no. If we're looking at it from a microscopic perspective and we're getting MRIs or doing even some lab samples where people have done biopsies and so forth, there is such thing as a partial tear, but it's usually more that this has just been a chronic condition.
So a partial tear is, you may have a couple fibers intact.
Yeah.
But, okay.
And it's like, if you've got an endpoint and your Achilles is functioning, then you've got some different algorithms that you can go down.
So before we get to talking about fixing an Achilles, tendonitis, Achilles tendonitis, tightness, things like that, what can be done other than stretching? So you got to stretch, you need to do some PT.
Yep.
Do you put people in a boot occasionally? What can be done to offload, what they're feeling and avoid a potential tear?
Right. And so I think the big picture is ultimately you've got to get the pressure off of it, because that's the inciting event that's causing us to have the inflammation flare up in the first place. So the other options like boot, saying, okay, you hurt really bad today, let's get this thing to settle down so when you're walking and so forth, it's not causing much of a problem. So boot's reasonable.
And what does the boot do for them that
so then it makes it so you're not having to push off as hard directly through your Achilles complex, and so it allows it to calm down.
So they can still bear weight, don't have to be crutches, but
right.
Okay.
Right. And so it allows you, it's always a balance. And so it's like, okay, this hurts and I know this is really annoying, but you still got to live your life. You still got to go to work. You still got to, get kids out of bed. You still got to, do all your stuff. And it's like, how can we balance this so then we can still allow your life to continue? Because that's never going to stop.
Right.
And then also getting your Achilles better at the same time. So boot, you can do some heel wedges. So kind of like giving you a little heel lift where it's just kind of pumping up your heel, kind of like think of it like a high heel, just trying to get some pressure off of it. And all that's trying to calm the inflammation down.
Why can't you just throw a little cortisone in there?
cortisone in tendons I don't like because it increases your rupture rate.
Okay.
And so, yes, steroids, if you're doing it into a joint or something like that, you can get inflammation to go down. And yeah, if you inject it in there, it can cause the inflammation to go down, but then also your rupture rate goes up. And so injecting it isn't a good idea. There are some options, though, with physical therapy, and it's called iontophoresis, where you do like a topical, whether it be steroid or anti-inflammatory, and they use like ultrasound and other things.
So you prescribe that?
Yeah, to try to drive it down in there. And we have seen some good benefit with that and be able to avoid. But once again, that's controlling the inflammation, but it's not controlling the cause.
What about the orthobiologic options? That's becoming more in focus, and we're trying to find some avenues. Is there any in your mind, in your practice, is there any role for it?
I think the biggest thing is it has a role in the respect that if we're looking at all this and somebody's got bad tendonitis, a young athlete, and something where they're like, hey, you know what, I do not want to go through the surgical recovery and so forth. Is it an option? Yeah, because there's definitely the healing factors, and they've shown that there's some anti-inflammatory benefit and a lot of other things that can promote the healing of the tendon in the area.
But not yet standard of care for
right. And so the tough thing is if I lined up 10 people, who out of those 10 people is going to see the significant benefit from it? That's what's hard to tell right now, because I don't think that we've fine-tuned it in where it's like, hey, you do X, Y, and Z, and this is, in that algorithm of boom, this is going to be a home run for you. It's a, hey, you know what? If we're kind of out of options and surgery is what's left and this is all we have, you know what? I would say kind of like in those situations, the biggest side or drawback of it is it makes your wallet a little bit lighter, unfortunately, and trying to, once again, never be insensitive to that fact whatsoever, because that's 100% real. But it's hard to be able to give that strong confidence that this is going to be the home run that you're hoping for.
So besides tendonitis, or maybe this is a component of tendonitis, you can get a spur that attaches to your heel, correct?
Yep.
The calcaneus.
Yeah.
And you can get a spur there that potentially can irritate things?
Yeah, completely. And so
what do you do if you've tried everything that doesn't work? Is there surgery that can fix that?
Yeah, there is. And once again, kind of understanding why people have the spur in the first place. And so I get kind of simplifying things. I would say bone is dumb. All bone knows how to do is make more bone. And so if you're pulling hard with your Achilles on the bone, then the bone tries to protect itself, and then that's where the spur develops from.
Okay.
And so it's the tightness that's causing the spur and the irritation. But then what happens is that on the back of the heel, well, whether it be with just shoe wear that we have in American culture, but then also additionally, there's just not a lot of space back there, and so tissues are tight over the top of it, and then the spur also becomes a problem. And so kind of differentiating whether it's a tightness problem or if it's an actual spur problem kind of determines some of that. Okay. But if it is, hey, you know what, this spur hurts and it's right on the bump, this is killing me, I've done all that easy stuff, you can go in and take that spur off, and so then you smooth it out, but then you also...
To get to that spur, you have to take the Achilles off?
Yeah, to be able to get a good approach, in my opinion, that's what you need to do, because there are some ways that you can try to kind of skirt taking the whole thing down, but what happens is that where that scar tissue is, where that spur wraps around, we're kind of cutting corners to be able to do that. And so taking it down, and there's some great reattachment options now that I'm really confident in. And so, it doesn't slow down the process very much. Okay. And I think that the reason we're doing surgery is because of the bump. So do we want to cut corners to maybe not get all the bump?
No.
And that's why you're there. And so it's like, okay, maybe it takes an extra week or two of, cooling it and not walking on your foot. But in the big picture,
at least it's not going to recur on them.
Exactly. And so that's the whole thing, is that then you're addressing why you're there. And when you sit back and it's like, yeah, that stinks. I don't want to do another couple weeks of not walking on it. But it's like, okay, but that's the whole reason why I'm here. And it's usually a pretty short conversation.
So those attachment options, I would assume, are, you put some anchors in the bone or things like that.
Yeah.
When the Achilles actually ruptures itself, describe that location and where that usually occurs.
Yeah, usually it's higher up.
Okay.
There are instances where it actually pulls off the bone. I'd say that's more of the exception than the norm. Usually what happens is kind of like if you feel the back of your ankle, kind of where that cord is, that's your Achilles, and kind of that area that you most commonly feel, that's where it ruptures. And the reason that that's the problematic area is because that's where the blood supply is bad. You get blood supply from the top, you get blood supply from the bottom, and that middle is the watershed area. Kind of, once again, simplifying things, going back to like geography and elementary school and middle school, is that's that watershed area. And so it's problematic tendon, extra pressure, that's where it pops. And so you end up going in and you just sew the two ends together, reapproximating the tension, and then you slowly stretch it out as you're going.
Where is your incision? Do you go straight? posterior?
I go over the top of it.
You do?
Yeah, and so
Okay.
we kind of do a smaller incision. It's not too big. From how you mobilize your tensions and so forth, you can get access through a pretty small approach in the grand scheme of things.
And obviously, wound healing's one of the major complications that can happen.
Yeah,
right?
for the exact same reason.
Okay.
And so it's the exact same thing.
Vascularity.
It's the vascularity. It's the same blood flow that goes to the skin as it goes to the tendon. You know, I say that, your thigh, you got that big beefy muscle there that brings all that good blood flow. There's nothing back there. And so going slow at the beginning to get that incision to heal up. And then after that, then we can start getting people stretching and so forth. Starting at really 2 weeks, we start working on that range of motion and getting that tendon pumping.
You're in early rehab protocol?
Yeah.
Okay.
Yeah, I'm an early rehab
Weight
person.
burn right away?
And so I let them use balance at 2 weeks.
Yep.
And we start working range of motion. And so it's really balance from 2 to 6, but range of motion starting right away at that 2 week point once the incision looks good. So 2 weeks of locked up for the incision purpose.
And then you go to a boot then?
Yeah, and I put people in boots at 2 weeks. And then everything else, though, is that there's so much from a rehab perspective. Not only we need to give the tendon time to do its thing, but we also got to get all the other soft tissues going. We've got to get your foot just getting the fluid pumping through. We got to get you touching your foot. We got to get water running over the top of your foot from a stimulation perspective. And you just feel so much better in a boot when you can shower. You can wear regular clothes. Right. It's just life once again.
Yep.
It allows you to continue on when this other stuff is getting better, but it just takes time.
Is there someone who shouldn't have their Achilles fixed? I remember a point and counterpoint thing I attended 10 years ago where they had an article that said, you don't even need to fix Achilles anymore. And I was like, this sounds crazy to me. But are there some people that, hey, non-operative care is the way to go?
Completely. And, from a total nerdy perspective, I'll talk to my buddies that are foot and ankle surgeons across the country, and, we share notes all the time, picking each other's brains and such. But every once in a while it'll be like, Butler, you're such a bad athlete now since you're old that I don't think I'd even fix your Achilles anymore.
Oh, okay.
So it's like total nerdy thing, but just to dig at somebody.
Yeah, that's the medical joke that no one gets of you buddies.
Yeah, that's when my wife from the other room tells me to be quiet.
Yeah.
That type of a thing. But no, the thing is that there's a lot of situations where you don't have to. And the studies that have come out that says you don't have to fix Achilles, they're more of a unique situation. And a lot of that literature is coming out of Canada. And how they've done an amazing job of educating their general population of, you tear your Achilles, you don't walk on it at all. Like, it pops on the court, you get carried off the court, and you're in a clinic within 24 hours.
So then you splint it with the ankle
and
equinus?
Yeah, but then you put your foot down, your foot on the gas pedal, and you splint them like that to get those ends reapproximated right out of the gate.
This has got to take forever, though, compared to mobilization.
It is slower. It is slower, and there's been some good studies within the U.S. military that have been able to compare them. They've shown that they've equal on both sides been able to get people back to activity, but you're looking at there's a couple months difference of being able to return back to whether it even just be walking, jogging, further advanced activities. And so in somebody that doesn't have high medical complications, whether they've been walking on it or not, kind of the decision comes in. It's like, okay, you know what, I just got to, once again, I got to get on with my life. The world doesn't stop in these types of situations.
So why do some athletes take a year to get back?
It's the confidence.
It's just
thing.
Confidence. So could they go back at 6 months?
So from a strength perspective, yes, but like, once again, just kind of referencing some of the people you talked about, is like Durant's return got delayed because of some of the COVID stuff, but also he thought he was going to come back before that, and he was slowed up with some of where he was supposed to be on his rehab.
Okay.
And then even like Kobe, he was like, he was cutting, jumping, doing all this stuff, but he's like, man, I'd go up hard on the side that he tore, and he's like, I could do toe rises, I could do leg presses, all that stuff, equal strength. He's like, I would go up, nothing was there. And he's like, it was just like, it's just your body just doesn't trust it. Yeah. And that just takes time. And
we know, confidence from ACL reconstruction, mental is as big as physical. So it's the same, essentially the same thing.
Yeah. And so it goes back to the 13 months.
Is their strength, will it truly get to become the same?
Will
their explosion level be the same as they were?
In the big picture, yes.
Okay.
I think that's kind of a little bit on a grading perspective of taking things in context. Because like if you take professional athletes that have everything at their disposal and it's like, hey, I got to push as hard as I can or else I'm going to retire. They've shown that they're getting pretty darn close, like within a standard deviation of what you'd consider as being normal.
Okay.
From a recreational athlete perspective, what ends up happening is that we get to 6 months and we're like, hey, I don't trust this and this has been going on for a long time. A lot of times you just find something else to do, or you play differently, or you say, hey, you know what, maybe this is the sign I shouldn't be playing pickup with my buddies every Saturday morning. And so you then go find something else. And they're like, I'll never tell somebody to stop doing stuff. It's like, go, be active. But then people change, and then it's like, okay, do we truly know? Because it's like, hey, are you playing basketball anymore? No, but I quit for other reasons because I found something else.
Exactly. Why is it that age group? Like, why doesn't a rookie in the NBA tear their Achilles when a 10-year vet does? Why does, as you were telling me, you have a bunch of basketball coaches that are our age or a little bit older coaching their kids that tear? What is it about is it the aging process? Is the tendon weaker?
Also we just get tighter as we get older.
Okay.
And so it's, if you could tell if you talk to an athlete that's playing at 40, what could you tell your 20-year-old self? Stretch more. It's just that you just gradually get tighter, and so it takes longer to get loosened up. And so it's that tightness, that's that extra strain on the tendon, and that's the big picture that causes it to pop.
And this is an embarrassing question, but if you have a long Achilles versus cankles, are you at increased risk for long Achilles versus having really short Achilles, do you think? I'm asking for a friend who has a cankles, okay? I just want to know, if I should keep playing basketball or not.
I would say theoretically it may be protective. You can tell your friend that.
having a shorter tendon.
Yeah,
okay.
I was gonna say the cankles may be protective.
It seems like it would just be protective, right?
Yeah, because the
lever arm and
and the muscle just has good blood supply, and so you've got muscle that extends down lower.
Yeah,
and so you've got your blood supply goes down further. Because if we're talking about certain options from a reconstructive perspective, when the Achilles is completely trashed,
I'll let my friend know. Be happy to know.
One of the options is bringing in kind of a muscle belly from one of the tendons underneath.
And doing for reconstruction if you need more tissue.
Yeah. And so
FHL,
so bringing in the big toe tendon.
Okay.
And the reason that works great is not only is it close by, it's in the same phase of gait, so your brain trusts it to push off at the same time, so you don't have to rethink about how to walk.
Yeah.
But it also, you've got the blood supply because that muscle goes lower. And so you bring that in, and it brings great blood supply.
How often are you doing that to augment?
I don't necessarily do it in primary cases because,
revisions.
In revisions that they didn't heal, or somebody that's had long-standing scar tissue in the tendon, and you got to go in, and the problem is that you got the scar tissue. You got to get the scar tissue out, or else we don't solve that problem. And then you kind of usually get left with a very wimpy Achilles that's left, or something potentially nothing at all, and you got a gap. And so then you're augmenting and using this to bridge your gap, and then you bring in the blood supply, and they heal up pretty darn well in the grand scheme of things.
Okay. Well, Paul, you are a substantial addition over the last 4 years to this community. Your expertise and your leadership that you've already demonstrated is amazing, and no doubt it's benefited patients in Ankeny and Iowa statewide. So thank you very much for coming on tonight.
I appreciate it. Thanks for having me.
Yeah, absolutely.